Today I'll go through an update on sedation, analgesia, and muscle relaxant in ventilated patients, specifically in ICU. So, what are the general questions in regarding sedation and analgesia? What comes in our mind? Is it an important issue? Do we practice it daily? Are there evidence-based guidelines? And what is the best practice? What are the various monitoring scales and what are the deviations in the practice? So, today's my presentation will be surrounding this general questions regarding analgesia. So, how evolution of sedation and management in ICU is evolved? So it's just a question when the ICU starts, when the branch of critical care starts in 1993. And the sedation guidelines first they came in 1995. Then effect of sedation protocol, effect of daily awakening trials, Society of Critical Care Medicine guidelines, introduction of analgosedations. So over a period of first 10 years, there are evolved drugs. Now from 2008 to 2016, many ventilated patients, like we come with ARDS, then other swine flu has come. So ventilated patients are going to increase. So whether the deep sedation is needed, how the patient should not be awake on the ventilation. So many guidelines came. Nowadays, what we are practicing, we are not practicing deep muscle relaxant. So how it evolves, it comes to only sedation and analgesia because of the critical illness myopathy. So we are using very less muscle relaxants, but we are using it. What are the objective today's lecture is? Why do patient need sedation paralysis in ICU? What are the aims of sedation? What are the guidelines? Do you have enough evidence to use the drugs? Do these appropriate practices change our outcomes? And what are the appropriate and inappropriate practices? Because of course, a patient we put for anesthesia is just for a few hours during our anesthesia practice. But in ICU, the patient will be 8 days, 10 days, depend on his conditions, neuro conditions, his sepsis conditions, depending on his traumatic brain injury conditions, and sometimes for ARDS. There is no brain or other organs involved, only the respiratory system is involved. So we want the patient to be come out very nicely from the ventilator. Analgesia, sedation is very important in such type of patient who are one month on ventilator. So what are the problems with the agitation? Why this thought process comes with agitation in the ICU? It increases the oxygen consumption, it increases the ventilator dysynchrony, inadvertent removal of the devices and catheter. The patients are agitated, they just remove the catheters. 12% self or unintentionally extubated, 50% agitated at the time of extubation, only 20% received some sedation. So we just want how smoothly we intubate and extubate the patient in the OT. We just want the smooth extubation in the ICU also. So what are the effects of lack of analgesia? Untreated pain, long-lasting psychological effects, tachycardia, hypertension, raised ICP, increase in systemic vascular resistance, increase in myocardial oxygen consumption, which is very deleterious for the patients of MI or any post-plasty patient. The myocardial oxygen consumption, we just want to decrease it. The demand also we want to decrease. So with the precise control of pain, reduce the need for deep sedation and reduce the necessity for muscle relaxant. So pain part of it is more focused nowadays. What is the aim of analgesia and sedation? Effect of alleviation of pain and anxiety, better control of patients on mechanical ventilation, avoid of self-manuring, amnesia of the bad events, psychological well-being, prevention of exhaustion and depression, adequate sleep, there is no recall of the unpleasant event, blunting of autonomic responses, reduce the requirement of relaxant, and to facilitate nursing care, transport, and management. Sedations, we are doing some type of sedations for the specific purpose. In COPD, acute exacerbation, to decrease the self-drive. In acute hypoxemic respiratory failure, patient ventilator dysynchrony. In ARDS, we want sometimes inverse ratio, sometimes less. We just want 35 the respiratory rate. We want the pH to be down. So we want a deep sedation and relaxant. Raise ICP to decrease the reflex stimulation. In acidosis to decrease the respiratory rate. Chest trauma to improve the pain, and substance abuse decrease the withdrawal symptoms. So these are only for sedations. So what are the observations in ICU sedation? Common observations. It's basically neglected area. Decision often left to the juniors. Poor clinical assessment and understanding. Benzodiazepines are preferred and narcotics use are less. Lack of protocols and poor drug selection, and appropriate dosing, poor use of monitoring skills. The survey has conducted by ISSCM, still the top of the drug in during sedation, analgesia, common practices in many ICUs still a midazolam, 26%. Then comes propofol, then comes fentanyl. Fentanyl is actually because of the less availability, because only anesthesiologists can be used. That's why it is having a less use. Dexmedetomidine, of course, it's 16.6%, but still the favorite drug is midazolam. The recommended practice of giving analgesia before sedation almost non-existent. We observe that it's almost they're not thinking about the analgesia part of it. Just midazolam and propofol. They intubate the patient with midazolam and propofol. Delirium remains the under-recognized entity. Monitoring of the sedation level and analgesia and delirium is low. Validated and recommended scales limited use, and practice implementation is very low. Now know your drugs. What are the drugs? Propofol, benzodiazepine, thiopental, alpha-2 agonist, dexmed, haloperidol, NSAIDs, ketamine, and opioids. We all know these drugs. What is the property of an ideal sedative? It should be rapid onset and offset, minimal respiratory depression, because many a times we just scared of giving sedation for a patient on BiPAP. But how many days he will be on BiPAP? 1, 2, 3. We have seen COVID. Their respiratory rate just decreased, and we just want some sedation. If they got sedated, then we have to intubate. So we don't want intubation also. So we want a drug which is having a less respiratory repression. No effect on cardiovascular system, inactive and lack of metabolites, because ICU patients are MODs most of the times. Any patients like having a liver or kidney dysfunction. So we want a drug which is having a lack of metabolites, independent on renal and hepatic function, no drug interaction, no pain on, because multiple drugs are going on in ICU, no pain on injection, no tolerance or withdrawal, amnesic and inexpensive. I don't think there is no ideal sedative, but we are trying to give an ideal sedation and analgesia to our patients. So, what are the properties of commonly used benzodiazepines? Everyone knows midazolam, lorazepam, and diazepam, and midazolam most commonly used. The duration is only 2 hours. So, we are not using lorazepam and diazepam in ICU because we want the patient of ventilator to come out also to see the extubation trial, to see the weaning trials. But it is not having an analgesia effect. So it's for the sedation purpose. It's a good drug, midazolam. Other sedatives are propofol, haloperidol, and dexmed. So amongst all, the propofol is the most common choice drug. But still, I'm using propofol, but I feel the dosing and should be used very properly in a very less dose, just a required a sedation dose. It is sedative, hypnotic with no analgesia. GABA receptor antagonist, rapid onset, loading dose is 0.5 to 2, maintenance 1 to 6, ideal for continuous infusion. Maximum recommended dose is 4. Recovery is 10 minutes, but it can accumulate with prolonged use. And caution with elderly septic hypovolemic. Actually, in ICU, the septic patients will go on ventilator. The hypovolemic patients sometimes go on ventilator, and elderly also go on ventilator. So, what is my observation is propofol we are using only for intubation purpose, not for prolonged infusion, because it causes propofol infusion syndrome, cardiac failure from sudden bradycardia, metabolic acidosis, hyperkalemia, rhabdomyolysis, and if the dose is above 4 to 5 milligram per hour, considering checking pH, lactate, we have to continuously check on. So we are using propofol in ICU only for intubation. Dexmed, it's sedative, analgesic, and hypnotic. When Dexmed came into the market, at that time we thought that yes, we have overcome all the problems of ICU. But the recommendation is not more than 24 or 48 hours. But still, off-label use people are using for 48 hours. But limited primarily by kidneys, short acting, loading dose is 0.5 to 1, and maintenance is 0.2 to 0.7. Even we are using in anesthesia very more this drug, and its dose adjustment is not needed. In renal, hepatic, and dysfunctions, and bradycardia and hypotension are the side effect. But we have to watch. What we have observed is bradycardia is more with dexmedetomidine. That's just a bradycardia, and below 45 we have to give sometimes atropine. But more than 48 hours we are not using this drug. There is trial meta-analysis of random controlled trials. It results because it's a very famous drug. 28 trials randomized 3,648 patients, 1,870 to dexmedetomidine and 1,778 to control. Dexmedetomidine was associated with significant reduction in the ICU in the length of stay. So it's a good drug. Haloperidol used to treat episodes of delirium. Dose is in increments. It's produced mild sedation without analgesia and amnesia, has opioid and benzodiazepine sparing effect, decrease the seizure thresholds, circulation stability, but pro-arrhythmogenic in ISD and prolonged QT. So again, whenever you are using haloperidol for delirium, I think once or twice dose they are using because it is pro-arrhythmogenic, and many a times patients of arrhythmias are there in the ICU. Ketamine, very less used in ICU, but if the ICU is headed by an anesthesiologist, ketamine is also preferred in septic patients. General anesthetic agent, good analgesia, used mainly for intubation, preferred for hemodynamic stability, and no proven effect on ICP. They previously used to say ICP is raised. We are not recommending patients with raised ICP this drug, but there is no proven for once an intubation in a hypotensive patients. Analgesia now come with. So, what are the drugs available with us? Morphine, pentazocine, and fentanyl. Amongst all, is fentanyl is most favorite for everyone. The dosing is everything is given in the chart, and everyone knows about it. But why fentanyl preferred over morphine and pentazocine? Because of the side effects. So, pentazocine is still used in many ICU, and fentanyl is commonly used in ICU because it is having a metabolism by hepatic in renal, but still in cardio safety and other safety, many ICUs are using fentanyl. It's having a bradycardia as a side effect, but still we are using this drug on a ventilated patients. Newer opioids, the availability and the cost. So again, a fentanyl has highest score. Remifentanil is an ideal drug, but still because it's metabolism, ester hydrolysis. So many of patients on hepatic and renal problems, we can shift to remifentanil, but because of its availability, we are still using fentanyl. So fentanyl is a potent synthetic opioid, most commonly used. Short-acting opioid with rapid onset, half-life is only 30 to 60 minutes, does not accumulate in renal failure, suitable in hemodynamically unstable patient. So this is the cause of becoming fentanyl as a famous drug in the ICU because of the hemodynamically unstable patients only coming in the ICU. Second drug is used, I have seen, is tramadol and centrally acting analgesic, weak mu receptor agonist, 50 to 100 milligrams slow bolus, enhance serotonin neurotransmission, nausea, vomiting, and ondansetron can block the analgesic effect, contraindicated in epilepsy, minimal depression in the high doses. So tramadol most of the time can be used as analgesia in many ICUs. Paracetamol round the clock for post-operative patients in ICU they are using, but in analgesia and sedation, like in a ventilated patient, sometimes fevers come, so we can use 1 gram 8 hourly in that patient, which gives you analgesia plus antipyretic effect. And during that period, it's an observation the paralysis and the sedation of the requirement has decreased. It's a popular addition and having a limited analgesia, but we are using. Now the next main drug now it's come into the market is Nalfi. So many times we are tend to use the off-label use. So off-label use of Norfi has been started using in the ICU settings also. What's the difference is having a analgesia and sedation effect. So both you can't think about two drugs, one analgesia and sedation and one paralyzing agent. So this Nalfi is having both. It provides sedation as well as analgesia, useful in procedures, lower risk of respiratory depression, and than other opioids. It is causing a safer options in many susceptible patients. So, what are the FDA approved uses of this drug? Is moderate to severe pain relief, analgesia during labor and delivery, adjunct to anesthesia post-operative pain, and off-label indications: chronic pain management, palliative care, emergency department analgesia, and sedation in intensive care unit. So, this under two headings, like if trauma patients comes or he's likely to get intubated, and also in for sedations also in ICU intensive care unit, if you require mild sedations having a less respiratory depression, so we are nowadays started using Nalfi. These are the mechanism and comparison of the Nalfi with fentanyl, morphine, and pentazocine. If you observed, is many of actions of Nalfi are similar to pentazocine. It's having a dual action, and respiratory depression is less than fentanyl. Fentanyl, of course, respiratory depression is less in less doses, but in high doses, it's having a higher risk. And sedative property of Nalfi is produces sedation. It's having an additionally anti-shivering effect. Anti-inflammatory effect is also in addition. And pruritus risk is, I think, less than fentanyl. But they have not mentioned whether it is better than fentanyl in the pruritus, but it's having a lower risk. Now come to muscle relaxants. Muscle relaxant, everybody knows neuromuscular blockers uses in India is like Vecuronium still on the top is 50.53. Even if Atracuronium comes in the market, its only use is 38%. Its elimination is Hoffman's elimination. But I don't know why this drug has not becoming popular than Vecuronium. Still many ICUs are using Vecuronium because of the, I think, bronchospasmic effect of Atracuronium. Many scared of using this drug during in ARDS or any respiratory like COPD and other. So that's why Vecuronium is still popular. Rocuronium and succinylcholine is very less. Succinylcholine, I think, because of the cases of malignant hyperthermia and all, people are not using it for intubation also. So succinylcholine use is very decreasing. Before 10 years, the use was very high. Nowadays, people are shifted to rocuronium. So properties of ideal muscle relaxant. Everyone knows succinylcholine is depolarizing, other are non-depolarizing. and the side effects are brady and hyperkalemia. And succinylcholine, you have to think a lot while using it. But other relaxant drugs, intubation with sedation, analgesia, and ICU intubations are emergency intubation, and then they can give Vecuronium. So, what are the ideal drugs? So, there is no ideal drugs, but rocuronium and atracuronium use is increasing nowadays in ICU. And atracuronium, the metabolism is ester hydrolysis. So, these are the complications of neuromuscular blockade, and we want less use of neuromuscular blockade in ARDS and in prolonged ventilated patients. That's why we have thought of sedation and good analgesic. So, what are the complications of neuromuscular blockage? Prolonged weakness, unpredictable delay in recovery, limitations in presence of hepatic and renal dysfunctions, acute quadriplegic myopathy syndrome. EMG shows denervation of the muscles, increased incidence of myopathy with concurrent steroid use. Many a times sepsis or ARDS, or now the sepsis guidelines include steroids, ARDS include steroids, and many neuro infections also have steroids. So steroids use is very often in ICU, and that increases the neuromuscular blockade actions. Now we have discussed the drugs. What are the problems of excessive sedation? Why we want a smooth extubation and early recovery in the ICU settings? It causes respiratory depression, bradycardia, hypotension, ileus, thromboembolism, undetected acute neurological events. Excessive sedation can cause significant morbidity and mortality in critical illness. Excessive sedation delays the liberation from ventilation and increased risk of delirium and long-term cognitive impairment. So agitation can also cause problems, and excessive sedations can also cause problems. So we have to balance the sedations, and the I feel ICU sedation analgesia should be a decision of a senior, not a junior. So sedation assessment, vital signs, sedation scales, BIS monitoring. BIS monitoring is not there in many ICUs, but in Mumbai and other metropolitan cities, now they started with the BIS monitoring. Conscious sedation, muscle relaxation stimulator, even in resource limited setting, we are not using. But in higher centers, they are using stimulators nowadays. Analgesia, autonomic and somatic response, and pain scales. We want to give comfort to our patients. So which scales we are using? Are we using it daily? Are we calculating? As if I'm taking a round on a ventilated patients, we usually see fast hug BID, like feeding, analgesia, everything. So during analgesia, am I daily measuring his RAM scale or Ramsey scale or visual analytic scales? So we have to think a lot. There are many monitoring scales in sedations available. These are the BIS range guidelines, and RAM scales is most commonly used. So daily interruption of the sedation is needed. Why? Because there are studies which found 2.4 fewer days on mechanical ventilation, 3.5 fewer days in the ICU, 50% reduction in the total benzodiazepine use, and pairing the deep sedation interruption with the spontaneous breathing that reduce the ventilator and 1 year mortality. So these are the benefits of daily interruption of the sedation. The ACCM recommendation 2013 of analgesia and sedations are opioids as a first choice of analgesia. Tramadol has opioid sparing effect. Gabapentin, carbamazepine for the neuropathic pain. Epidural analgesia preferred in thoracic trauma. Propofol and dexamethasone are preferred over benzodiazepine. Fentanyl plus benzodiazepine superior to benzodiazepine alone. It causes delirium. Haloperidol for delirium. So pain and agitation. If the patient is conscious, he will tell he is in pain. If the patient is unconscious, you have to assess his pain levels, his lines, everything is there, bed sores are there. Many a time trauma patient, the fracture, he won't complain when he's on ventilator. So you only have to assist it. First line drugs is opioid. If no, at risk of opioid side effects, yes. If the pain is nociceptive, you have to think about multimodal analgesia, acetaminophen, neopharm, low dose ketamine, ketorolac, and neuropathic agent. The pain is neuropathic pain, like patient is diabetic and having a neuropathic pain, so you have to give neuropathic agents. So pain management should be on priority in every ICU patients, whether he is conscious, disoriented, agitated, or on ventilated. Analgesia supplements opioids. NSAIDs, acetaminophen can be used as adjunct opioid analgesia in critically ill patients. Gabapentin, carbamazepine, and pregabalin can be used with opioid for neuropathic pain management, and low-dose ketamine can be used as an adjunct in opioid for pain management. Now, agitation. Pain हो गया, अभी agitations. We have to correct the reversible cause of his agitation. Many times in ICU, we have to talk with the patient why he is agitated, why he is irritable, whether he just want a relatives with him, whether he is in delirious state, he's 8 days in ICU. So we have to correct the reversible cause. Yes, just give haloperidol, just sedate him, just give him little fentanyl, just give. No, we have to correct the cause, reversible cause, if it is at all reversible. And then you think about the drugs. Then there are two management, non-pharmacological management and pharmacological management. If the non-pharmacological management works, it's very good, because many a days they have not seen the sun and suddenly they become conscious. You have to ambulate the patient. So these are some corrective measures you have to do. Then in analgesia part of it, if unstable, of course, fentanyl, remifentanil, ketamine. If stable, you can use morphine, but still I am not sure anybody is using morphine in India that much unless and until in a cancer or moribund patient. Sedatives, midazolam is the still preferred choice, propofol and dexamide. These three drugs that are preferred choice and they are only using in our ICUs. Control of delirium can be with dexmedetomidine because causing less sedation and haloperidol. Now, from a whole my lectures, the take-home message from this lecture is we have to give a case-based approach to each and every patient which is getting admitted, and we have to think about analgesia and sedation start from the admission in the ICU. So cardiac patients, of course, we are using, if MI patient comes to us, then we have to give him painkillers also. So from that angle, we have to think. And in cardiac and pulmonary edema, of course, sometimes they go on ventilator. So we have to avoid propofol in cardiac and pulmonary edema patients. We have to give shift to fentanyl. Neuro cases with low GCS and IC bleed or any neuro patients, we can use propofol, muscle relaxant, and we have to avoid ketamine because ICP thought to आता है ICP no proven effect but it will raise. So propofol and muscle relaxant in neuro cases. Cardiac, we have to avoid propofol. COPD with acute exacerbation, dexmed, avoid as far as midazolam and fentanyl. But in COPD with acute exacerbation, even if you want to use fentanyl or little midazolam, it has to be very 1/4 dose, very, very low dose you have to use. Otherwise, these patients, they get intubated immediately. COPD for intubation is fentanyl, midazolam, of course, a choice because they are all the famous drugs. Circulatory shock, we have to think before giving midazolam and relaxant because the patient will go again in shock, hypotension, arrest many times. So you have to think. So you have to use ketamine, midazolam low dose, and relaxant. So ketamine will increase his BP, keep his BP, and keep him alive. ARDS, this is the most difficult task to ventilate these patients for 1 month. So the combo drugs are always there, 4 to 5 drugs we are using: midazolam, fentanyl, relaxant, dexmed. Prolonged infusions, titrate according, avoid prolonged infusion, titrate according to the requirement. We still use very low dose of relaxant because midazolam and fentanyl used more will decrease our requirement of relaxant. Summary from my this lecture, tips for ICU sedation is we have to prioritize pain assessment and management, target and awake interactive patients shortly after intubation, multimodality symptoms based management, use non-pharmacological interventions for patient comfort and engagement, avoid benzodiazepine, particularly infusions, and identify iatrogenic benzodiazepine and opioid withdrawal, remove unnecessarily catheters, and be attentive about nighttime sedations. Thank you.